to the flag of the United States of America, and to the republic with which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. Public comment? Hearing none. Move to the consent agenda. Has everybody had a chance to look at the minutes? Any questions?
I sort of move we accept the consent agenda.
Second. Been moved and seconded to approve the consent agenda as presented. All those in favor? Aye. Passes unanimously. Okay, lightning speed. Our financials.
Hey, this is not gonna be lightning speed, sorry.
We didn't get
I
to
will
see
try
anything.
not to.
Did you send anything out?
I did not. I
I thought maybe you
spent
just missed
the
it.
day in my office just running on my hamster wheel as fast as I could all day. So we are definitely still in the steep part of our learning curve for our new financials and all of the things that go with it. And to further help us out for 2020, both of my accountants had pre-surgical appointments this week, so they were out and it was fine.
Did you have the auditors coming in? And
The auditors are here, yes, we're in the audit, and there's just all kinds of great stuff going on.
Had a nice chat with one of them today.
Oh, yeah.
Okay.
Yeah, Dave Ines, he's a nice, great guy.
Yeah.
Okay, so actually, we did really end up making some good progress. It just took me all the way till today to get it done. I had to put it in Excel, I had to make it look better. I haven't reviewed it to the total extent that I would like to, so I'm gonna take a little bit more time tomorrow morning to look at all the details before I send them to you. I would be very grateful if you would really look at them very closely and question everything that doesn't make sense to you. We're changing the format, we're changing the way we look at things, and so we have the same numbers, but they've moved pots a little bit.
Are you gonna have the comparatives too?
I do, this month I've got comparatives, and I've got the budget. I can't really compare it to last year, because the things are in different places. The summaries, we can't look at the details. You'll make more sense when you look at it. So, anyway, I mean, also had trouble with the stats, but we're making progress. So, I actually am pretty excited. It's not coming out of the system as plain as it is. I want to be able just to push a button and have all these reports print. I mean, that's the way it should be. And we're getting there, but we're a long way from there. So, I did actually, I got it done, and we had a good month, we had a positive month. Other than that, it's pretty average. So, to begin with, let's talk about COVID money. I don't know, there's been a lot of news about COVID money this week. A week and a half ago, on Saturday, the HHS sent out this declaration to everybody that all of a sudden really changed the rules on reporting on the CARES money. And it said, in a nutshell, you can only count net patient revenue into your losses, and it can't be more than you had last year.
Is this the PPP program or the CARES?
No, this is CARES. This is CARES. So,
Are you gonna get to those dollar amounts you're talking about in your report of CARES?
I will, this is very new. I mean, I just learned more about it this morning. They have the CFO meeting every week on Thursday morning, and we talk about it. This is very brand new. And there's a whole lot of unhappy people all across the US. So the American Hospital Association is fighting it, and OAHS is fighting it, and all the CFOs were very stressed out about it because this really, really changes things out of the blue. And so a lot of people are very stressed out about it. Yes, I will figure out what I think it means. But I'll tell you off the top of my head, it means we might have to give a few $1 million back on that because we thought we were keeping the whole thing. But then, just a few hours ago, we get another.
As of October 1st, HHS announced $20 billion is now available to supplant what you didn't.
And
I went through the report and, they specifically targeted mental health and, because of the concern of anxiety over, self, isolation and increased substance use disorder and other conditions. And there was one other area.
we talk about how they're gonna look at income, your income differently and your loss of income. Because we were,
So you're saying that we get some more new money?
That just came out today. Again, 2 sets of information that we're finding out this week. We don't know enough about the impact of this.
But we carried the CARES programs as liabilities.
we did, but they came out and said, the CPAs and all the people at the top of the food chain said, go ahead and record that as money, you get to
Well,
keep
it's
that.
money, but it's,
No, you get to keep it, it's grant money, you record it as,
The
Income.
PPP money we treated as loan.
right, but we had the 2 categories, the CARES money and the PPP money and some other money.
right?
Some of the CARES money we treated as grants, correct? But some of
We,
it
at
was
first,
loan.
we recorded it as a grant and left it there for several months.
Right.
But then the government said, go ahead and record that. And like one of the guys, a CFO in a larger hospital today, was very upset because he's already published financial statements and had his audit, and now he's gonna have to go back because he recorded all that as revenue. I mean, it doesn't make any sense.
Okay, but we still have that money in the bank.
Yes, we do. We do.
But you may have to do something, you may have to do something with that.
We may have to do something with that.
So it's gonna put some stress on us.
It might, I don't, maybe it'll
Plus
take
the
the money.
90 billion, you may be down at mental health.
Yeah.
Well, yeah, so
So,
then, in addition to that, this week, I began the process of applying for forgiveness for the SBA PPP loan. Yeah, new subject,
Moving to the PPP side.
PPP loan, $5 million.
Right.
Everything looks like we will have it be completely forgiven. We have to wait several weeks for them to review and approve our application, but that should be completely forgiven. So that's $5 million. And then, another thing I learned, okay, the Medicare, repayments. So we were supposed to start paying that back in 3 months, and they were gonna take all of our Medicare funding, so all the new Medicare money, they're gonna take it all. So now, as of this week, we're now going to have 29 months to pay back the money without interest. So we aren't going to have to make our first payment until a year from the first deferral money that we got.
So will they withhold that from their Medicare payments to us?
Yes.
Or we're going to actually?
For 11 months, they will withhold 25% of our payments. And for the following 6 months, they will withhold 50% of our payments. And if we haven't paid it off by the end of 29 months, we can pay it off at the rate we wish, but we will pay 4% interest. Now, it was gonna be 10, so it's down to 4. So this is the new repayment plan.
With that money.
Yes, yeah, they would
Come
go
on, you
do,
said just, let me share.
that's
Yeah.
totally how I feel.
That is what we deal with
Yeah.
on a regular basis.
Because these are big bucks.
These are big,
Big.
these are big
For
changes.
us,
Dollars,
I mean,
yes.
And so when Cheryl and I learned about some of these changes, she said, do you think we should tell the board? Because we don't even know if this is real.
I feel
the
like
answer is no, don't tell us.
Yeah, we'd rather be in the dark.
And the answer is,
It'll change next week.
It's okay, full disclosure, I like it.
we're not gonna withhold any information that, even if they come back and say, relocate. We changed our mind.
We made a mistake. I think that's the best part about listening to all the CFOs and orders and talk. It's just like, God, I thought it was just me. I mean, what am I missing here? I'm having a panic attack, but it's okay.
So that's why we tell people.
All right.
You're telling yourself it's only money.
It's just my paycheck. All right. All right, so last month we didn't have this slide and we didn't have very many stats. One of the things I learned this morning is, we all had a really great June and now we're starting to decline again. We're not exactly sure why, but you see that here. We did decline from 360 to 288 patients. I am not getting any information out of radiology or rehab on the number of visits.
Is that because of the Cerner changeover?
It is because of the Cerner, and July, of course, they had to use two different systems, and August is all Cerner, and the managers are kind of struggling a little bit. But Sheila and I have been talking, and she assured me that next month, the report that she's gonna give me is going to knock my socks off, so I'm kind of excited about that. So this is kind of pieced together from what I could find out from various parts. So, but just a decline, fewer swing beds. Surgery was not bad, but fewer inpatient. Quite a few less in the ED. Babies, you never know what's gonna happen with those. So, I can tell you a little, but I can't tell you a lot. Monthly gross charges. Last month we had 2.7, this month we had 2.39. Not bad, but we budgeted for 4.1. So,
Last month was always,
yes.
Yeah.
Yes. I mean, really all things considered, it's not bad, but it's below. Collections on accounts receivable were very low, 1.876 million. But please remember, we're in the middle of the Cerner go live. These 2 months are supposed to be our worst months. So this should not surprise us at all. This was supposed to happen, and it did. So 1.87 million. September looks like 2.345 million. So kind of a bounce back. That's good news. Late breaking news.
Yeah, very late. Hot off the press. Estimated figures.
But probably pretty close. Okay, our days cash on hand dropped from 81 to 77. Again, I'm not surprised because, our revenue's a little bit slow and collections are definitely slow. So, we need to be at 90. Or it's
That doesn't include any of the CARES money or the PPP.
No. Well, it includes the CARES money because I'm reporting it as the revenue. I mean, we took it out of the liability bucket and restricted bucket, put it in, but so if I have to give up 2 million, I'll probably gain 5 million, so we're still sort of okay here.
but I think before when we finally book our PPP money, we have to set up like, you don't want to be in a comparison situation again with our
Right,
budget, so we really have to,
especially until we get the Cerner revenue cycle really working well, until we know that it's where it's gonna need to be. And so, that could be several months under normal circumstances. Most people take a year to get great at, so. Okay. Profit and loss for August. We had a little bit more revenue, a little bit more net revenue. Wages, or total wages and benefits were really close month to month. Expenses 3.3 and 3.1. I don't know why expenses are down, that's another thing I kind of need to look at overall, but our net income for the month was 140,000. So year to date, we're at 98, and we had budgeted to be at 305.
you don't think there's delay in the receivables.
No, payables are very, very current. We've been in multi-view for several months, so all the expenses are really right there. And we might be missing some revenue, but I don't think it's super significant.
Yeah, not as significant, there's a couple things that we're working on. great work with them as far as going back and looking at a spreadsheet, but most everything is all there, it's just which bucket do we wanna put it in. We look at our spreadsheet.
So tomorrow I will have a detailed P&L for you. I need to do some tweaking to that. I'm gonna try to get some of those duplicates out so it's less confusing. But I'll have those for you.
And as you can see, we have different categories. So there's lots of different ways that allows us to look at it and say, well, what about this? Or why are we doing? So it's still a lot of tumble.
It is, and however, part of the reason why we chose these categories is because it's more of an industry standard, so it makes it easier for us to compare ourselves to other people, because that's what most people are doing. It was a good time to say, okay, let's go,
You just revised the chart of accounts.
kind of, yeah.
What's the difference between net patient AR and receivable?
Well, receivables are like receivable from Lakeview Gardens. So this is only patient AR. This is receivable from other sources. And I have a detailed balance sheet for you guys tomorrow too. And so the receivables to my name is not the greatest descriptor of it, but it includes Lakeview Gardens and DME and
Isn't it tax rate?
no, just no, we don't record receivables for tax revenue, so anyway, this detail is not very good, but it's all non-AR receivable. So, not a big change in our balance sheet, month to month. And it didn't print out the detail of fixed assets, so to keep the depreciation. And I couldn't figure out how to get it, so I have to wait till tomorrow to have somebody teach me. I got the net number, I just didn't get the details, so. And today I learned that if you don't post one of your journal entries, your balance sheet isn't gonna balance. That was a good learning for anyway, a lot of fun on that. Okay. Aren't you glad that I checked to see if the balance sheet balanced?
That's a good thing.
See, people don't, like Joe. Okay, any questions on before we talk about unbudgeted items?
Questions? Okay, move on to unbudgeted items. It's our license strikes.
So we have a couple things. I sent out to everyone the opportunity to purchase the replacement light fixtures to take advantage of the monies from energy trust. I found out today that the work has to be done by November 1st, not December 1st. But we got the first set of lights for our central utility plant. And the guys got it all installed, and it's all working today.
Good.
So we got one component completed. So they're already working. So I would ask that we approve and I sent you all the details. The total is $35,270. It does not, there will be a little bit more because it will include the food share building, it will include some off-site locations where we have the opportunity to change out. And we still have not gotten that information.
But this had a payback in less than 2 years.
Oh my goodness, yes. In some cases, it's very short because of the nature. What changes and why it's different is the kind of bulbs, the kind of fixtures. That's really the biggest.
You're removing ballast and putting in LED, isn't that correct?
All of it's LED. Sometimes they're removing ballasts and just putting in the LED strip.
Right.
Sometimes they're replacing the fixture. It depends on, and they went through and determined what is the most economical. And that's what they are, that's why we use this company. Their recommended parties, they are a partner with Energy Trust to do this.
Chairman, I would so move that we approve the $35,270 plus the cost for off-site for lighting.
Second.
It also does not include the labor. So our laborers, but there are maintenance guys that are doing it. So
Right.
that is just for purchasing. I just want to be clear.
We're doing it all in-house.
Yes. If we cannot meet the deadline, then we would have to call in one of the local contractors to help us. Because the penalty is steep if we don't.
So we can recoup our costs within a couple of years or less. Well, after that, what would be a monthly or yearly savings over current?
Well, if you looked at our, this new set of information that shows our utility costs, it's about $45,000 a month in our utility costs. About 20,000 of that, just shy of that, is in geothermal. Okay, and that is predominantly paying for the infrastructure put in pipe, because we had a big portion of that. And we shared that with the school district. The other 20,000 roughly is our electric bill, which is a significant component of that is our lighting. They have given us rough estimates of what they think our savings will be. But I think it's far more prudent to see, once we've got them all installed, we'll start seeing the difference, and we'll report that to you. We should be done by December 1st, and we should be able to tell you what kind, you'll be able to see what kind of energy savings we're actually going to experience.
Well, if it has less than a 2-year payback, it's gonna be $1,000 a year.
Exactly.
I would expect it. So even though they've estimated it, I believe they have an estimating, they estimate a little bit high. But I don't know.
But the baseline would be a savings. I'm sure that the audience knows.
I would expect that we should see a significance.
At least 1,000 a month, if not more.
Oh, and that's,
I'd be concerned.
so thank you for that. I have,
So we have a motion on the floor. We move to approve the lighting change out plus the offsite cost.
Yes.
And Ken seconded that motion. All those in favor?
Aye.
Passes unanimously.
I have another item that came up. I got it yesterday, did not send it out to you. And it became absolutely critical that we, and I signed the contract before the time. And that is the way, when the new hospital was built, we went to a computerized system for balancing our heating and air conditioning. So when as it warms up, the temperature, it tells the system to increase the amount of airflow for cold air. Then it opens the dampers throughout the areas within the organization. It's a very sophisticated system. They're called JACEs. You've heard it, JACE, J-A-C-E. We have many throughout the organization, JACEs. They normally last between 5 and 10 years. They die. And our system is 10 years old. And they died yesterday. And the replacement cost is about $40,000.
Is that
And
for
we knew.
all, is that for all of these?
No, it's for the principal areas that we are concerned about. So acute, the one in OR has not died yet. And pharmacy in the lab. So now it has to be manually adjusted. We have to have somebody's going through and telling it, move this valve, increase this heat or this cooling system. It'll be, we hope they'll get here in 10 days. But we knew it was coming. The hard part is you can't replace these bit by bit because you don't replace them until they break. So we've been budgeting, well, we'll probably have to replace them. Maybe we'll replace one at a time or something. No, we didn't have that option.
The current staff didn't make the installation, or we have to have somebody from the outside?
It's done by an outside. And anytime we have any trouble, the company that does the monitoring and there's a lot, this is a very complicated system. They do it out of work. And it's all done through the internet. And they can't even contact her. The Portland guys can't access our system. So we've had trouble before, fixed some of the computer components. But this does not require board approval, I'm just telling you, because this is a maintenance. But it was certainly not something I was hoping would happen. We had no choice. So what I know.
Okay. Goose Lake Medical Services. We're in the same position there as financials as we are with district.
No, not really, because they're still in point of care and we are using multi-view, but they're just not as complicated as possible. So, stat-wise, they're very close to where they were last year at this time with 47 added days. We sort of are seeing more people in long-term care, less in assisted living, based on year over year, but overall about the same number of residents. Our gross charges are $246K for long-term care and $36,000 for assisted living. Last year's average for assisted living was 49, so we're seeing a decline in patients and the revenue and increase related.
Census, by the way, today was 11 in the assisted living, 21 in long-term care. So we're very close. And remember, it's very restrictive for people to come in because they are our most vulnerable. And we certainly, while we haven't had a big surge in COVID patients, we want to protect them more than anything else.
So P&L, we lost $80,000 this month, which is a lot closer to where we really need to be, and down from 164 last month. I really feel like these fluctuations have a lot to do with contract labor. The bills don't come in on a really predictable basis. So I think it's just fluctuations, it's not a huge difference. Because of how close our revenue is.
What is other expenses? It was big in July.
Sure was big in July, look that up because I don't know that off the top of my head.
Okay.
Or it's in the wrong place, it needs to be fixed.
That wouldn't be our tax rate.
No, the taxes, we usually accrue that and the tax would be, well, you're right, yes, it should be. We should have accrued for it. But I'll look it up and I'll let you know when I send your financials. Alright, that's it.
Okay, any other questions? Hearing none. Ambulance service update, Troy, you're on.
Well, I just want to introduce myself and take this time to give you all an update on where we're at with the implementation of the ambulance service area and the transition of it from the Lakeview disaster unit to the Lake Health District. So I want to thank all of you for helping get to this point with the project to not only sustain but enhance the services that we're providing in a pre-hospital emergency service condition to the ASA. So as September 1st, we took over the ASA, and since then we've been running extremely well. We've been able to have 24/7 advanced life support coverage to the community. So basically we've been able to have a paramedic on every initial out truck. We've had multiple times where we've had simultaneous calls of service. Just as this afternoon, we had several motor vehicle accidents where we had to have multiple ambulances responding. So we've been able to provide ALS care to all of our patients that we've been able to encounter.
So you had a paramedic on all 3 calls?
So this afternoon, we had them on 2 of the trucks, and we had an advanced EMT on the 3rd truck. So yeah. And the 2 ambulances that were coming from Lakeview is where our paramedics were, and then the 3rd ambulance that's in the Adel area, primarily serviced with our volunteer group out there. They had an advanced that was able to assist with that very, very so. We're continuing to not only utilize our full-time staff, which includes myself, another paramedic, and an advanced EMT, but we're still really relying and needing those EMS volunteers from the disaster unit. So
the staff, did you say that the current staffing is today?
There's 3 of us currently, 3 full-time employees. That's myself, I'm a paramedic. I have 1 more paramedic, and then an advanced EMT. HR is working with an offer to another paramedic currently for a full-time position. And so currently we're utilizing the 3 full-time employees supplemented by our volunteers from the disaster unit. Some of the things.
Roy,
Yes, sir.
when you're at, what staffing level will you finally want to be at? What?
Our goal would be to hire 3 more full-time employees. That would allow us a good coverage of not only 911 response capabilities, but getting to that point where we'd like to be to provide the inter-facility transfers to the tertiary care centers. Because we want to not only be able to provide that service to our community, but we need to maintain 911 coverage as well for any emergency calls that might come in. So, and that would allow us to do that with continued utilization of the volunteers from the disaster unit that have onboarded as EMS volunteers with our hospital. Some of the other things that we're looking at in the strategic plan from the service area is we're looking at a computer-based electronic healthcare record system for the ambulance. Currently, we're doing paper charting for all of our patient care reports, and that's a mandate through OHA, through Oregon Health Authority, that we have to do some sort of a computer-based reporting system.
Were you using one where you were before?
Yeah, we were using ESO, and so that system that we've looked at not only has the capabilities, we've been working with a team within the hospital to ensure that that has a billing interface with Cerner to communicate with Cerner, but also has a ability to have connection when we don't have the internet, and we're able to still do those reports, because a lot of our ambulance service area, we're not going to have data out in the field. So we wanted to look at a system where we could start that report and did not require an internet connection. And so this would provide both of those. We're also looking at the use of the computer-aided dispatch system. So currently, when we get dispatched, the ambulances are at the emergency services building. Dispatch is located in the same area. They're able to print out a report that gives us the address and kind of a little bit of information on the call. We're looking at, since we're located at the new EMS building, responding from there, utilizing a system where we can log into dispatch and actually see that information in real time and let our ambulance providers actually see updated information as dispatch is putting that into the system. I mentioned inter-facility transfers. Once we get to the point where we are fully staffed and have a good plan for resource utilization as far as our apparatus and our ambulances, we'll be able to start that service as well. And then long term, what we'd like to do is look at what a community paramedicine program would look like here, and that would be utilizing our paramedics in their downtime to go out to those people who have been discharged from the ER that might be at risk of readmission, and going out to make sure that these people are compliant with their medications and do well-being checks on them to just make sure that they're following up with any discharge instructions. Looking at our current apparatus, we leased 7 vehicles from the Lakeview Disaster Unit. 3 of those have been licensed by the Oregon Health Authority as transport ambulances. One of those vehicles is a rescue truck that primarily transports our rescue equipment, including airbags, a set of Jaws of Life, and any additional rope rescue gear, any saws and anything that we might need for that. And then there's also two first response vehicles, one located in Adel, one located in Plush, that would allow the volunteers to respond and start rendering aid before an ambulance can receive the dispatch and get there. So two of the three licensed ambulances, two of those are located here in Lakeview. One of those is equipped with rescue equipment as well. One is located in Adel and has rescue equipment on it as well. Our strategic plan for apparatus, when we looked at the budget, is thank you all for allowing the budget of a non-transport vehicle. So that vehicle would be, we're looking at a Chevy Tahoe, and that would allow us, for example, today there was two motor vehicle accidents out in the Adel area. So the volunteers were able to respond. We had a basic level crew that responded. Instead of sending an ambulance out there with a paramedic on it, we could have had the paramedic respond in this vehicle and assist that crew out there and still maintain ambulance coverage for the city. And the second type of apparatus that we're looking at is another ambulance, and that would be to ensure that we were able to provide that interfacility transfer program, along with providing 911 coverage to the rest of the ambulance service.
Has the Tahoe type vehicle been ordered or?
It has not. We actually just made some progress on that today. We looked at two different options. We looked at what a new vehicle would be, and then we looked at what the Tahoe is a demo unit. So basically, sometimes these fire apparatus companies will take a vehicle, they'll build it, they'll equip it with emergency lights, sirens, and all the equipment, and then they'll never sell it. They'll just utilize it to go to every department in the area and kind of show what their capabilities are of building a unit. So this unit that we're looking at, it's never been assigned to any call. It's never been utilized by a department. It's only been utilized to display what this company is able to provide. And that gives us a little bit more of a cost-effective option and a little bit more of a quicker option than trying to buy something new that we would have to wait 60 to 90 days to be built for us. Whereas this vehicle that we're looking at is located in the East Coast, and they could have that to us within the 2-week time frame. So
It's already got the lights.
it already has the lights. All we're going to have to do with it is equip it with a radio for communications, and then any of our medical necessity equipment that we would need. So it would be a very quick turnaround time on getting that vehicle in service once it's ordered. Personnel, we did touch a little bit on that. 3 full-time, just continue to utilize our volunteers to the full extent. Our personnel strategic plan, again, hiring additional of 3 full-time EMS personnel. And what we would mainly do is utilize EMS personnel on an on-duty type of situation during the day where they could be working on some of these things as far as going through our trainings, our fleet maintenance, making sure that the vehicles are ready daily, making anything that we need to do as far as accommodations for repairs. And then at this point, with our call volume, we would maintain an on-call status overnight. So we do have sleeping quarters here in the facility, and we're able to provide that coverage with 24/7 coverage as well. The other thing that we've been looking at, and I've been working on as a strategic plan, is what it's going to cost to outfit each person. So we're an interesting ambulance service area because we not only provide EMS services, but we provide rescue service as well. So in that, we have to provide personal protective equipment for when we're doing vehicle extrication and rope rescue. So that entails a little bit of a more specialized uniform. And so we're looking at getting our volunteers, our full-time staff equipped with not only that equipment, but uniforms and communication equipment, so pagers and radios, so we're able to receive the calls and communicate with dispatch. Finally, looking at the EMS building, we plan to begin operations out of that on Monday the 5th, and we will continue to share that operational space with the business office with our strategic plan to begin full operations out of that on the 5th, and then continue to grow into it as we're able to. So if there's any questions, I'd be more than happy to help.
Have you had a chance to go out to Plush and Adel and meet the volunteers out there yet?
I have, and one of the other things, I haven't been to the Plush station yet, but I've been able to meet all of our volunteers. We're in the process. I think we have 4 volunteers that the disaster unit had that have not onboarded, but they have appointments to begin onboarding. I went out to Adel, assessed that ambulance, looked at the condition of it, and like I said, there's 2 vehicles out there. There's a first response vehicle and an ambulance out there with rescue equipment. So I plan to run out to the Plus station in the next coming weeks, and then kind of assess what we are there. But I've met all of our volunteers. We've been able to have trainings together, been able to continue to, again, utilize their training schedule, and we're looking at what they're used to and what works for them on a volunteer basis. And so I think it's a good transition for them so far as well.
And how about with 911, have you had the chance to interact with that department?
I have, and Charlie and I had met with the town manager and Scott Utley, the 911 dispatcher, I guess that was last week. And so we're working towards a memorandum of understanding with the town to utilize that dispatch service. Of course, they're going through some changes as well, I think, on that side of the house. But one of the biggest things is we want to be able to utilize that computer-aided dispatch system, so we're getting that real-time contact information. And then the other thing is for their personnel to kind of get used to, we're not fully volunteer anymore. We're going to have that crew on board. So when we've looked at the calls that we've had in September and looking back prior to that, it's hard for volunteers to get away from work. It's hard for the volunteers to provide the service to the community sometimes, especially when they're working during the day. So there have been times in the past where the disaster unit has had struggles providing a crew simply because they are all volunteers, and it's hard to get them gone during the day. Since our transition, since the 1st of September, we've only had 2 times, 2 calls of service, which we've had to dispatch more than once to get a crew. And so all of the other dispatches, all the other calls of service, we've only had to have 1 dispatch, and we've been able to provide a crew that responded immediately. And again, that would not be possible without the utilization of those volunteers and our full-time staff and having that mixture. So we really need to continue that relationship between the volunteers and the full-time staff.
Is there any specific areas such as Plus that still has some communication difficulties?
Yeah, absolutely. So the calls of service that we had about 30 miles east of Adel today, that's a learning curve in itself, trying to figure out which frequency to utilize and where we're, what communication system to use. Obviously, cell phones have struggles out there. Radio communications have struggles out there. And that's where we want to make sure that we have a good radio system in each ambulance, and we're able to hit the repeaters about 90% of the time, I'd say, from what I've seen in the county. So we're continuing to look at that, make sure that we have a good communication coverage, and then working with the emergency services coordinator for the county to see if we need to have any of those areas that don't have good coverage, and look at the repeater coverage if we need to implement something. But we're doing pretty good. The most difficult part is just realizing which frequency to utilize where you're at in the county.
So for your move-in on Monday, you have all the stuff you need as far as beds and tables and be fully moved in next week?
To begin operations, absolutely. We have the lodging set up, so we have 4 bedrooms upstairs that are fully equipped with beds, nightstands, closets for staff to utilize. We have a workstation for our emergency service personnel to utilize to provide reports and everything. Basically, the only thing that we won't fully begin to implement is the training area. We are continuing to share that space with the business office. So we won't move, and we have a good plan for that. So we won't need that space to be utilized till we're able to find another spot for them to go, and then we can start utilizing that. But we have a good plan to begin operations out of the building.
Once you get moved in, perhaps you could get the door.
Yes, I'd like that, absolutely.
Yeah.
Excellent. Any other questions?
Welcome.
Thank you.
I
Welcome
appreciate it.
aboard.
Thank you.
Thank you.
Very thorough briefing, I like it. Thank you. Okay, moving right along. Ms. Minetti.
Yes. Well, my update probably won't be near as comprehensive as Troy's there, but I do have some things that I think are pretty exciting for the ER. When Teresa asked me to come this morning, I thought I'd bring some of the QI that we have. I'll walk through this with you. I will I will not be back after the meeting. Keep our QI information pretty close to our chest. So even this year, with all of the changes we've been doing, and I've been so proud of the staff, keeping up with all the recommendations that COVID has brought us.
What does QI mean?
QI is our quality improvement. Our staff has kept up really well. As you guys probably know, do you want one to look at right now? Okay. The recommendations in the past 6 months have changed quite a bit. And nursing staff has done excellent keeping up with the fast pace of it. And one thing I track pretty closely is our high acuity, low frequency patients. So these are patients coming in to the ER with a major trauma, with an active stroke, active chest pain or heart attack, or septic from an infection. And we want to make sure that in these big these times that I guess we've had, times of change with COVID and our normal process changing, that we're not delaying any care to these really emergent patients. So the first page I have for you is our stroke patients. Now this data is about the last four-year trend. Yep. So you can see these are in minutes. That first top one is the door to dock assessment. So from when the patient comes in our door in the hospital, how fast does it take the doctor to get to their bedside? I track these. Our goal is less than 30 minutes. That's what we're required by the state. And anything that falls out of that, we look at with a fine-tooth comb, as myself, and the provider who was on that day, as well as the medical director. So we always look at every case that falls out to see if this is a single one-off incident or if there's a process that we need to improve. You can probably see the big.
This is for any emergency entrance.
This top one is for stroke only.
Stroke.
Sorry, I think I missed that. Yeah, so just our acute stroke patients that are coming. Although we track the time on all of them, on all of those critical patients, that's what this first page is.
There's a big leap in the first quarter.
First quarter of this year, yes. I know that one case that we actually had our provider in helping a woman have a baby. So he was in the house and we were talking the whole time, but it did take a while for him to get to that patient's bedside. However, the care was not delayed at all. The patient got to CT really fast, labs were drawn, and by the time the doctor got there, everything was kind of buttoned up and ready, and he was in communication with the staff the whole time. But our rules are rules, and it has to be at the bedside, so that was the number we tracked. The next one is that stroke patient, how fast they're able to get to the CT scan, because that's really what this patient needs if they're having an acute stroke, is that CAT scan of their brain, so we can start to assess what's going on. We look at all of these to see, where the outliers are. Sometimes it has to do with the time of day. Our call staff come in at night, and if patients arrive to the hospital without ambulance, or if they don't call us first, sometimes it takes a while for that night shift staff to get things going and to get them to CT, because we're not fully staffed at night with a rad tech on board.
There's always somebody on call.
100%. Always somebody on call, and they have a 30-minute response time, which we usually don't get close to. It's more around 12 to 15 minutes for all of our lab and radiology staff. The next page, the second page, this is still stroke patients. When they're admitted, we want to make sure that they get our full services, including rehab, so that's speech, PT, and OT, which we have a great comprehensive program. Not all patients are appropriate for that, and you'll see the holes in this graph are actually patients who chose not to have aggressive care and who chose to move toward the comfort or end-of-life care option. The one on the bottom of this is a dysphagia screen. So this one is fairly new to nursing in the past few years. One thing that's common with stroke patients is a difficulty of maintaining their airway or being able to swallow food and water, which can lead to complications in their weeks of recovery. So the sooner we get this screen done, the better and safer it will be for them. So
This is a
that's,
test. This is some kind of test.
it is. It's just a simple test at the bedside that the nurse does. So I coach individually the nurses who fall out on that. The last couple of pieces I have for you are trauma. See, now this is a pretty big colorful graph. We want all of these, my goal is to have all of these full over to 100%. That's always our goal for patient care. So these are trauma patients only for the last 6 quarters. That top part has to do with their vital signs on admission and discharge that are taken within 10 minutes of either. So within 10 minutes of getting there and within 10 minutes before they leave. Kind of gives us a good window. That second column is related to patients who have had neck trauma. We want to make sure we do certain tests and to see if their neck, their spine is clear before we take off the collar. The next two have to do with charting and documentation. And I would say that the fifth one down, when our patients go to x-ray, what I'm looking for there is that it's in the chart that the patient went with the tech and with the nurse on the monitor to x-ray. Most of these, when I circle back to the nurses, I find that maybe they forgot to document something or they documented it in a way that I wasn't looking for. So a lot of that is education on our state form that we use for trauma, which is different than our documentation form. Our trauma team always responds very quickly without delay. Just one exception there, and then if we have to document who responded on our trauma team. That's something from the state. They want to know the individual names of the lab tech that responded or the rad tech that responded, so we can do coaching if needed. And not always those names are documented.
Why does the state need the names?
Oh, I don't know.
Do they know?
They have, I don't know. But they want the names of individual staff members that respond for each department. Which you can, depending on our staffing, we don't always have somebody there to write down in the right place in the chart, who responded. And I do not go into the time clock record to see who came in for that trauma patient. But,
we need to have the names here. I'm just curious about the state.
It's great to have the percentages. Do we have the numbers of people that are involved?
I could read those for you. I don't have the numbers of each quarter.
So when you say 80% for their
Sure.
10
So
people,
So for stroke patients, we have 2 to 8 a quarter on average.
okay, that's.
Yes.
that makes a
And
big
then
difference.
trauma patients are 6 to 12 a quarter.
Okay.
Our numbers are not high.
Right.
Which makes it even more important to do the quality improvement on them, because we have high standards of taking care of these patients, and just because we don't do it every day, that's no excuse not to give them the excellent care every time they come in. So we make a big deal of the data, even though they're low frequency items, they don't happen every day. Even for a nurse who works 2 or 3 days a week, that nurse may only get 1 or 2 trauma patients in a year, right? So it's important to keep these standards up and fresh for them, so they know what's expected every time. And then the pie chart is the first one on the left with the 3 areas of data. This is what happens to our trauma patients. So we activate a trauma team based on mechanism of injury often, right? If it sounds bad, it really could be bad, so we want to be prepared by having everybody in. But a decent number of those, a little over a quarter, end up going home from the ER. We're able to admit and care for half of our trauma patients here, and then we're transferring just a little under a quarter.
What's a GSW?
Gunshot wound. Less frequent than the horse or cow accident.
Yes, it's an ATV.
Yes, and
How many
then
horses do we have in the ER now?
I assume that most of the gunshot wounds are just accident, shot in the leg, foot, whatever.
they happen, yep.
Okay.
Any questions? I know that's a lot of data and I kind of went through super quick explaining it, but
Thank you, Abby.
any other questions on the ER or how we're doing on that end?
We appreciate that you're
Yeah.
there, watching all of this.
And,
I
ER
can collect
waiting room,
after.
Abby.
The ER waiting room, yes.
Anybody ever wait in there? Anybody ever utilize that?
You know, we don't have many people utilize the ER waiting room though. Do you have a thing?
Is that a design problem of the way it's set up, or?
We don't have the volume that I think would put people in the waiting room. You know, we have, let's look at our census. Off the top of my head, we're seeing 10 to 11 patients in a 24-hour period. You know, and maybe we'll have 3 or 4 at a time at our peak. Now we allow 1 or 2 visitors in with our patients, and they need to be in the room. They can't be in the hall. But even pre-COVID, we didn't utilize those very well.
John, I can answer. It's a design. When we designed the space, there were a lot of things that we thought it would be best utilized. And even the architects, when I talked to them about it, we have looked at the ER. What they said is, no matter what you design, you'll change your mind shortly after you build it. And it isn't because we were always wrong, it's because the way we practice has changed. An example of that, in our trauma room, in each corner we have had a place for cast sink, or casting materials. Well,
Cast, like you say, cast is somebody's.
what's happened is we don't use that casting material anymore. We use a different product. And so while we put them in there and we thought we were going to use them, the materials changed. So now it doesn't make sense to have those sinks. And they're very special because they have to trap the materials that before it gets, if you imagine casting material into the sewer system, creates a problem. So that's a simple example. We talked to architects about redesigning the space.
But is there a room, for instance, when the ambulance comes in, that they have a place where they can go and fill out their paperwork and do their things, or is that what you guys do?
Originally, we did not have a space. We changed. And we do have a space, so something else was used. Because there is so little space in the emergency room, the emergency department, anytime you move one thing, it has cascading impacts on it.
Maybe you move it to the waiting room when you're not using it.
Well, so if we move things into the waiting room, that means we may have to change how patient flow works. If we do that, then maybe we consider changing how the emergency vehicles come in. Then every time you make any slight change, there's a lot to it. So we started off with some design options, and it quickly got to in excess of $1 million to make minor modifications. So, while we didn't stop, we felt we could do some other remodeling first. But you can be assured we'll be coming to the board with a plan to redo the emergency, because they're emergency department, because there are just different ways of doing it.
It's change.
And that's a good thing.
Well, how long ago was it that they built that part?
And unfortunately, within the first year, we knew that we were gonna change. One of the things we thought originally was that we would put somebody, staffing-wise, in the waiting area. And what we found is we just didn't have enough people. Another thing we didn't really add that we kind of wished we had is an urgent care section of the emergency room. If you go to a larger hospital, they'll have 2 tracks, an emergency room and an urgent care. So a lot of people go to the emergency room because it is after hours and they can't get in, but they're really not life-threatening. They are urgent services. And if you do that, it costs less, and it also allows the staff to take care of the true life-threatening circumstances. We didn't accommodate for it. So it is something that we have to redesign. And it's on our radar. Thank you, Andrew.
Thank you. Okay, medical staff update.
Dr. Gallagher did not come because we did not have any information to bring to the board. We thought we could have a credentialing agreement with St. Charles for cardiology program. It's approved, and then we have some changes. We're going through and redoing some of that process, and so we will have in September some credentialing. But that's the reason he's not here.
Okay, thank you. Okay, item number 9, the CEO report.
It's only been 3 weeks since our last board meeting, so it's not much has happened. As always, things are, I shouldn't kid, but it is pretty busy. So a couple things. I don't know if all of you received a letter from the North Lake Health District, but Don did. Did all of you get a copy? So we got a certified letter saying that they're very upset that we have not signed a contract with them to use the 2 rooms that they set aside for us. We did sign an agreement with them. It wasn't a rate. They decided to tell us what that rate would be. And it'll be $10, or excuse me, $100 a month. And since we made the modifications in 2018, they asked that we pay back to September of 2018. We have done it, and we will continue to pay that fee. Part of the reason why we haven't used the space to the extent that North Lake Health District would like us to is it only accommodates 2 rooms, and we often have 3 people that need to be cared for in our mental health service. So it works, but it's not perfect. However, I received notification from the county that they would like us to evacuate the annex that we are using for both mental health and public health, and sooner than later would be great. So I approached North Lake Health District to see if we could rent additional space for both public health as well as mental health. And they were concerned about us moving forward if we weren't going to honor the agreement for 2 spaces.
The agreement had no
It never had a rate.
rate, just that was an agreement.
It was not the agreement that I suggested.
Shouldn't we do business in writing?
It wasn't right.
It is in writing, but there's no rate in the contract.
It said to be determined is how it
It
was
said to
worded.
be determined, and I said, great, let's, I'd be happy to talk about it. And unfortunately, I didn't know what the rate was until I went about 2 years later and said, what is it that the rate's gonna be? Because unfortunately, in order for us to provide any services as a health district in another health district's area, they have to have permission, written permission. I asked them for permission for first mental health, and they agreed to that. But when we took over public health 2 years and 3 months ago, they were still thinking about it. It took them about 1.5 years to answer.
So we were not providing the service.
No, we were still providing services. We were providing all the service because I didn't think they were not saying yes. They didn't have a reason not to say no. They didn't have a reason to say no. They just hadn't said yes. They did finally say yes. Right. A little convoluted, and I'm sorry for any confusion, but we do need to, the county would like to use the annex for the county business, so we've got to find another place. So we've got to look to find a solution.
There are two choices.
Well, there's always the option of considering other locations. So we just have to, it's another item to pick up. And we have to move quickly. So I just wanted you to know, we did get that letter. We have, we're moving forward. We received a letter from the state of Oregon that as of October 1st, as of today, all the critical access hospitals, type A and type B, the rate of tax that we pay into the Medicaid program goes from 5.5% to 6%. And 6% is the maximum amount that is allowed. Now, let me remind you how that works. All of the large hospitals have been paying the 6%, I believe, since 2012. The way the Medicaid program works is that each state has to tax itself a certain amount of money, and then it is sent to the federal government. The federal government will match that. It's a 2-to-1 or 3-to-1 match. And it comes back to the state, and that's how the Medicaid program is paid. When the CCOs got started, all of the type A and type B critical access hospitals get paid by the CCO. And we get paid what our costs are. We get paid on a monthly basis. So while we get quarterly, they take money out of our checking account of that amount. The money is put back into our account in 5 days, and we continue to get paid by the CCO on our regular payment. But it is a requirement of Medicaid. So while it is an increase in the money that they draw out of our account, we still get it back in 5 days. So just wanted you to know that change. This last April, I forget when, we were approached by members of the food chain to make some modifications to the building that we have that's given to us, so that we have 2 food bank food share programs. And the group that meets at the gathering place has expressed an interest in merging together, the 2 groups together, and wanted to know if they could use our building more aggressively than we could. To do that, there were some modifications to the building we needed. We finally have the proper quotes to make the modifications, and we've done some of the plumbing changes, but what we really need to do is build a walk-in freezer and a walk-in cooler. Right? They have currently our those sarcophagus freezers, the kind that they're, well, they're not sarcophagus.
Chest.
Chest.
I don't know what that means.
Well, you know,
It's close to Halloween, you know, you open it up.
anyway, so they have several of the chest freezers. Sorry, I always think of this as sarcophagus. Anyway, those are not very cost effective. And what they really need is, if they're going to receive lots of food and food bank out of Clement, it's very interesting to give them more frozen meals and frozen items. So we think that we can buy a walk-in freezer and build the walk-in cooler plus the parts. And we recently had a little trouble with our roof. There was a little problem with some of the portions of the roof. But in the last big winds that we had, turns out it blew off a portion of the roof. We have to fix it. Unfortunately, because of COVID and because of a lot of our contractors are unable to do it, we're just going to be able to patch that roof. Total cost, it was estimated by the food share team that it would be about $50,000. No, for all of these items. We were able to do it at around $18,000. We did budget for that. It's about $10,000 for the freezer, about $4,000 for the walk-in cooler. It still had then our labor. We will receive a grant of about $1,000 from the Climate Lake Food Bank. So net cost of about $18,000, $17,000 when it's all set.
That was in the budget.
It wasn't.
We have we have long-term planning for the roof.
Next spring, we will be able to replace it. This will patch it,
Right.
and it'll work properly. But what we found when wind blew it off is that they use sheetrock rather than plywood to sheet the roofing. So what we have to do is take all of the old roof off, fix it properly. We just don't have the time to get that done. So I just wanted the community to know that we are making steps in getting this done. So we have had trouble with some graffiti. We resolved that. We had a problem, if you recall, with the guy who replaced the front door. Trying to get in more than we anticipated. But we've resolved it. So it's moving, and I think that's a good thing. Rebecca can talk a little bit about programs if she'd like, but we have been going live with Chronos first with payroll and soon with HR. And we're scheduled, if I have my dates right, for October 16 and final everything. They'll be trained and going gangbusters by the 6th of November. Is that correct?
Yes, that's correct.
So lots and lots of learning, and everyone will be very pleased when it finally works and we're able to see the great results. Lots of changes for staff, sometimes good changes, sometimes they're challenging, but they're doing a great job getting that. In terms of software changes, we hired a consultant to help train our physicians. You may recall, not train, be as a supporting person to be right there at their elbow to help them using software. Jeff has been very useful to me. We're very happy with it. Not everybody is willing to take it, but bit by bit we're making it. That was a big challenge. I think I told you time and again. It's wonderful that our doctors have tried very, very hard, and they continue. It's not easy. The learning curve. But we are also now going in the training in the starting phase of certainly going for mental health. That going live will be April of 2021. So they're now in their orientation. One portion of the whack-a-mole pops up, and then you whack that, and another one, whack that. It's a constant story. I've been approached by the school to talk about nursing. If you recall, a year ago, we started having public health nurses going 1 day a week to the schools to provide nursing services, and that has been a wonderful thing. With a change in leadership at the school, the district is looking to actually hire a couple of nurses to, I think, have a full-time nurse. We are in discussions of what role we are going to play with that. We're still in discussions, and it is my hope that we will find some very good solutions so that our kids, even with all this COVID stuff going on, they get nursing services that really make a difference for those kids. So I thought we might have something finalized before tonight. We're not quite there. The only thing I can say is they hired one of our nurses. I wish they had. I wish they hired nurses from out of the community, but it doesn't always work like that. We also today extended our 23-bed license for the patients' rooms on the west wing. It was a temporary license granted to us for 6 months, and we extended that for another 6 months in the event there is an outbreak that we want to be prepared for. Our plan has been, should we be overwhelmed, that we would take patients that are not having the COVID conditions and move them to the west wing and have patients who require much more active care standard existing hospital. So we're technically licensed for 47 beds as of right now. We have not used them. We have beds in the rooms set up. But if you recall, that's one of the reasons why we have not relocated the business office back to where they were, because we're uncertain what could happen at this point. We have, did we give you, everybody get a copy of the conflict of interest annual statement? Okay, we will get you a copy of conflict of interest. I'd like everyone to look at that when you have a chance, sign that. It is recommended that we do that on an annual basis. What we'll probably do is shoot for the July date so we would catch the new members from the square. Make sure we do that. It's good practice. That concludes my comments unless you have additional questions of me.
We have for executive session. Okay. We'll then adjourn for 10 minutes and come back in executive session for ORS 192, bracket 660, bracket 2. Staff, E, real estate, and H, legal. 10 minutes.